Hello everyone. So today I'm going to talk about my factor review, which is about augmented feedback. And then I'll talk about my practice design, which is about strategy training for apraxia. So this is a brief overview of my presentation. So I'll talk about augmented feedback very briefly at the beginning, discuss some of its variants, and then concentrate on strategy training, first discussing what apraxia is. We'll just go over the schematic diagram of my training program, then we'll look into some of the basic steps, and at the end we will try to talk about strategy training in terms of this DS theory and some of the factors which affect motor learning before summarizing the points at the end. So, as far as augmented feedback is concerned, we need to understand what a feedback is. So, feedback is any sort of movement information which is given back to the learner for modifications and improve in performance. If it comes from inside due to the movement of the learner, that's intrinsic. Or if it is given from any source from outside, that's extrinsic. And the other name for extrinsic is augmented feedback, which is the main topic for our discussion today. Augmented feedback can be in the form of KR, or knowledge of result, or in the form of KP. If you just talk about success or failure, it's the KR, whether the task is accomplished or not. And if we talk about the characteristics and the quality, that's KP, or about the performance. Now, augmented feedback can be of three types: the visual augmented feedback, the audio augmented feedback, or if it's a combination of different modalities, that's multimodal augmented feedback. So, we'll just talk briefly about each of them. If we talk about visual augmented feedback, it is very critical because vision is the most important sensory modality, and that is why any feedback given through it is really important. It can be utilized in learning complex skills, let's say in a med school. It also it is also helpful in training older adults for gait training to avoid all kinds of falls, which is very common in old age. Feedback frequency is one topic where the findings are heterogeneous because we exactly don't know how much feedback frequency should be given and how the feedback should be taken away as the learner learns a particular skill. If we talk about auditory augmented feedback, this is also important because most of the times the visual sensory modality is overwhelmed. So if we provide an auditory augmented feedback, it somewhat provides a fresher perspective of learning things. So it helps in mitigating Parkinson's disease gait training. It's also helpful in people who are trying to learn doing motor movements through artificial prosthetic hands. And it's also helpful in normal healthy population if they are trying to learn instruments, for example, intonation learning kind of string instruments. So it has a variety of uses. However, as far as the multimodal augmented feedback is concerned, this is most significant because a combination of auditory, visual, or maybe tactile, if done in combination, proves most efficient and most effective in learning. And these are some of the examples. For example, if we see this skill training communication model, it has been used by athletic coaches where they adapt a question answer approach, a kind of a trial approach, or maybe a kind of an analogy approach in combination, and it proves very useful in enhancing performance. It's also helpful in prevention of ACL, anti-cruciate ligament injuries, where people are doing vertical jumps. And this kind of feedback actually mitigates the GRF or ground reaction force in those athletes. So, what is a strategy training for apraxia? For moving on to our factor of augmented feedback, let's talk about my training design, which is strategy training. The main aim of this strategy training is to teach standard occupational therapy program for carrying out activities of daily living or ADL for apraxia patients. So this is the main purpose of the program. So let's find out what apraxia is. Apraxia is a disease where it's the inability of a patient to perform purposeful and skilled movements despite the presence of sensory modality, motor modality, cognitive modality, but he is still not able to perform purposeful and skillful movements. An ideational type where there is problem with the conceptualization of a program, or it can be ideomotor where there is problem with the execution of a planned program. And these are some of the examples of activities of daily living that includes toileting, bathing, eating, feeding, dressing, grooming, and transferring, etc. So idea is that these patients are not able to perform ADL optimally, so we need to design a program, and that is what strategy program is for. This is a schematic view of my training program. So before starting the program, the activity will be chosen by the patient in discussion with the therapist, and then there will be two assessments. One of them is a general assessment, and the other one is the Bartle scale in order to assess the patient's skill level. At one time, two activities will be chosen out of eight, and these two will be practiced for 8 weeks. Three sessions will be conducted each week, and in each session of 30 minutes, for the first 15 minutes, one activity is practiced. For the next 15 minutes, another activity is practiced. And the same regime will be followed on first, second, third session in 1 week, and similarly for the first, second, and third session of second week. Once 6 training sessions are finished, the first two activities are finished, and we will move on to our activity 3 and 4, and so on. So in total, we have 8 ADL which will be taught through this training, and the total duration for this training is 8 weeks. In 1 week, as I've already said, 3 activities will be planned of 30 minutes each, so a total of 24 sessions will be allocated to train all these 8 ADLs. All right, so what are the basic steps of this strategy training? The first one is the initiation. That is the first phase if the patient has problem in initiating or starting the activity. For example, if you just don't know how to take the paste out, you can just show him, and once the paste is out, he can carry on brushing his teeth. There might be a problem during the execution phase, which is about the performance of the plan. So this is about brushing the teeth, although he was able to take the paste out, but he is not able to brush the teeth. Once the activity is finished, then the strategy trainer will tell the patient whether the activity is performed correctly or incorrectly, and what are the modifications which he can make. And he will provide these commands in a hierarchical fashion. For example, he'll start with a verbal command for all these three, or he may just start mimicking that how to do a brush, something like this. And even if the patient is not able to do that, then he will go and physically tell the patient that this is the way to do it. So these steps will be followed in a hierarchical fashion. If we see this strategy training from a dynamical system theory perspective, let's talk about the learner, which are the apraxia patients. So they have no sensory deficit, no motor deficit, no memory deficit, and there is no cognitive deficit which are present. If we see the skill level of the patients, a feedback will be given throughout and after the training in the form of a visual and auditory feedback, and there are sometimes extempore modifications made while training the patient. As far as environment is concerned, this will vary depending upon the skill. For example, if it's brushing the teeth, it will be performed in a bathroom, or if it's a kind of a stapling activity, which will be performed in a study. The patient will be cheered up, or his morale will be boosted throughout the activity, and there won't be any intrusion by the third person to make sure that he won't get conscious while learning the activity. There are much more things as far as the learner skill and environmental perspective are concerned, but for the sake of time, I just chose the most important ones. Now let's talk about the factors of motor learning which affects our strategy training. So, as far as the augmented feedback is concerned, I have already talked that the feedback will be provided in the form of audio and visual form, and that feedback will be provided in that 15 minutes of the first activity once it's finished, and then 15 minutes, and in the next 15 minutes of the second activity. So, as far as modeling and verbal cues are concerned, this has a huge impact in our strategy training because the instructor is a kind of a model who mimics things, and of the same thing, the patient is going to imitate things. And he will be providing verbal cues verbally in all phases of strategy training. So, this is quite important from my strategy training perspective. As far as distribution of practice is concerned, it is essentially a block practice. So two activities are chosen and they will be practiced again and again 6 times in 2 weeks, and then another set is chosen and we won't come back to the first one. So it's most typically a block practice design which is very low in contextual interference because we are not mixing different ADL practices. As far as part versus whole practice is concerned, this strategy training for ADL is high in organization and low in complexity. So it will be taught as a complete and it won't be broken down into parts. So it's a whole practice which will be practiced actually. And as far as variability is concerned, there won't be any variability in the practice. It's a constant practice design and it is very specific because the ADLs, for the strategy training for ADL will be practiced in the same environment where the patient is going to do once the particular activity is learned. So these are some of the things which we have talked, and if we look at the summary, we have talked about what augmentation feedback is, what are its variants, and then we just talked about strategy training. We'll first define apraxia, its types, the three basic steps about initiation, execution, and feedback. Then we talked about strategy training in terms of dynamic system theory, and we have also talked about strategy training in terms of the factors that affect motor learning. I hope this is a very quick presentation, and it's very difficult to impart all the things about training in such a short period of time. If you have any questions, I'll be more than happy to answer those specific questions. Also, at the end of the presentation, I have these three tables from my strategy training design: how to choose an ADL, what are the activities from which the patient has chosen his ADL, and this is a very detailed description of my strategy training. I just don't have time to go over it in detail, but if you have time, you are more than welcome to see it and give me a feedback or tell me if you have any questions. Thank you very much for watching this presentation.